car wreck comes in. And, so I'm not faulting the ER, but I do think you have to understand they work under tight constraints and limited resources sometimes, and if they make a mistake like that, it's not, obviously not intentional. But you should understand what's really going on when people present with cough and fever and whether or not they really have pneumonia. And so the natural history we're going to talk about a little bit. And then we'll talk about the treatment guidelines, about which there's considerable controversy.
Okay. Right arrow.
The right arrow?
Yeah.
So this first little block diagram is just the causes of community-acquired pneumonia in ambulatory patients. These are people who are diagnosed with pneumonia and then are treated as outpatients. What's the most common cause on the slide? When this study was done, this was a compilation of a number of studies in European. What's that? No. Unknown. Unknown. I mean, that's the only, that's, I know. That's a trick question. But the point is that it's rare if you can diagnose 40 to 50%, even have a probable guess on 40 to 50% of the patients present with pneumonia. It's a huge black box. And there's no good way to get good answers unless we do really expensive or unnecessarily invasive procedures, like if you did a bronchoscope and you lavaged the lung and you got, 10 to the 4th strep pneumonia per cc of lavage fluid, you would know they had that. But we don't do that because the risk of injury and cost and everything else is out of proportion to the benefit. But the downside of our current empiric approach, I'm losing this in more ways than one. But and the empiric approach is that there's no big drive to diagnose these other 40 to 50%. I mean, it's impressive. And yet we all act like we know what we're talking about when we say, in the ambulatory setting, you're more likely to see mycoplasma pneumonia, chlamydia pneumonia, and this is seasonal. Mycoplasma can be too, but especially chlamydia pneumonia, that's been shown to be up to 25% of cases on some university campuses in the wintertime. And then there's strep pneumonia, which is always in the mix, respiratory viruses, which is primarily influenza, A and B, and what's the other respiratory virus in adults that can cause pneumonia sporadically and be pretty severe. Actually, is also known to cause epidemics in military barracks and death in otherwise healthy young men. Do you know what that is? We used to diagnose that here when we had a lab that did viral cultures. Do you know what that is? That's an important one, because actually I'm sure we're still seeing it. We just don't know, we don't recognize it anymore because we didn't do a test for it. It's an adenovirus. So adenovirus can give you a shaggy, ragged pharyngitis and pulmonary infiltrates and high fever. In crowded conditions, it can spread epidemically in the summertime even. In fact, the last time we knew we had an adenovirus outbreak, it was in the summertime about, whenever we did this call, 15, 20 years ago. Gee, out of the crypts of this stuff. Anyway, and chlamydia pneumonia now has been renamed what? That's actually, you'll see it referred to still in most of this literature as that, but what's it called now? The microlab knows this. Oh, come on, you're killing me. They renamed it Chlamydophila. Yeah. Because they distinguish it from other chlamydia species, and it's usually been DNA sequencing. All these organisms, when you see them renamed, it's all because we've gone from doing empiric biochemical identification to DNA sequencing in research labs, and so they're the ones changing everything on you. And it keeps microbiologists in business and everybody else confused. But if you hear Chlamydophila, it's chlamydia pneumonia, not chlamydia trachomatis, which causes what? No, not syphilis, good grief. But it often is associated with syphilis because it's a sexually transmitted disease, yeah, STD. So you always have to check for syphilis, you're right. I mean, good association, but not causative. Yeah, just bad luck. But that's a different chlamydia. And there's one other chlamydia species that rarely causes pneumonia, and you would have to get a good history if you took this history. Chlamydia sjheducation. Do you know what that's called? What is it? No. Parrot fever, yeah. And so it's transmitted by infected birds, and it's pretty uncommon now. But in Montana, the last time I saw it, it was because the pet shops are violating the state law. State law says if you import a bird from outside the country, you have to quarantine it for 30 days on tetracycline saturated or tetracycline a feed that has tetracycline in it, right? That's expensive for those guys. And so corners are cut. And you won't see parrot fever unless somebody, and you rarely see parrot fever, somebody who's owned the parrot for a long period of time. It's almost always when they get them in the home recently. So if they haven't bought a parrot or another exotic bird within the last 30 to 60 days, it's highly unlikely it's worth chasing that potential cause down. But you've got to think of it, because it probably responds better to doxycycline than azithromycin or quinolones. And so it's a rare bird, pardon the pun, but it's worth knowing. And there was another case of chlamydia, sjheducation infection in Montana. There was a death of a pregnant woman up in Lewistown, but she didn't have pneumonia. She was in her second trimester and she got septic and died. And she had chorioamnionitis, so her placenta was infected, lost the baby, lost everything. And it turned out that she got it from lambing. And sheep will carry it asymptomatically, like buffalo do brucellosis, right? And so because of the birthing, exposure to the birthing fluid in the amniotic sac, she got infected, and when you're pregnant, you're immunocompromised. And so her inoculation was high enough. Well, you know, everybody in Montana thought, oh my gosh, an emerging disease. This is such a hoop, the way we're still like tunneled in as nations. An emerging disease. Well, if you talk to anybody from England, that's a law, a national law. You cannot land in England if you're pregnant, because they all have chlamydia sjheducation. It's just that nobody ever bothered to figure it out here. And probably it doesn't happen as often, so it wasn't worth the money to chase it. But there's lots of these unusual organisms causing not just pneumonia, but other infections elsewhere that we just don't understand because we don't talk enough or understand the literature outside. And that's a great example. But normally it's called parrot fever, and normally it's rare. It's usually when somebody's bought a parrot in the last 30 or 60 days from a pet shop that's violating the state health care. Is that helpful?
Do you ask patients that?
I do, absolutely. Oh, sure.
Do they think you're nuts?
They are. They decided that long before I asked that question. Usually, but that is worth asking, because I'd ask that question when I get asked to see a patient with pneumonia that's not responding to azithromycin, ceftriaxone. It's one of those organisms you have to think about, because it wouldn't, you know. Coxiella burnetii probably would, even though it isn't the first line. That's the rickettsia that causes Q pneumonia. And you get that, again, often from, it's carried in sheep, and it's an obligate intracellular pathogen that lasts as a cyst in the soil for 30 or 40 years. In fact, I know a guy that was diagnosed with Q fever, and he lived on a place, and I said, had sheep 45 years before. It was the last time there were sheep in that yard. 45 years later, just a dust exposure gave him Q fever pneumonia, inhalational pneumonia. So I ask exotic questions like this because people that don't respond to our empiric therapy, and we'll talk more about that, then you want to go looking for specific answers. Even though the empiric therapy works well, and I have to admit I have a changing opinion on the combination therapy, which we can talk about in a minute. But this is the spectrum of outpatients. There's clearly more atypical pneumonia agents like Mycoplasma chlamydia. If it was someplace in the east where it's more moist, you'd see Legionella, but that's a hydrophilic organism. It likes water. You know, live in Pittsburgh, and you have pneumonia, you'd probably have up to a 20% chance of having Legionella pneumonia. If you live in Butte, Montana, you have a less than probably 0.005 chance of having Legionella pneumonia. Yeah?
About the only way that I think most people get it in drier country, we had some down in Colorado. They were living in mobile homes with the old-fashioned water
coolers, swamp coolers.
Yeah,
Yeah, that's a common one. The only one I knew here was a postmortem diagnosis of that infamous placer miner in the Highlands. Do you remember him? He was the last placer miner up in the Highlands that the
Yeah.
Forest Service was trying to give the Butte to. And he came in and died of Pullman pneumonia. And at that time, we were still trying to culture it, and it grew 5 or 7 days after the sputum was collected. And then there were 3 cases in Warm Springs because of the cooling tower that got infected with Legionella. But it's very rare in our environment. Although, because it's so common everywhere else, there are national laws now. Are they driven by, what's that horrible organization?
OSHA?
Oh, no, yeah, that too. Oh, no, the recertification for hospitals and block.
JACO?
Yeah, JACO. I think this is partly driven by JACO, that all open water sources in your hospital, you have to culture them every year. And we grew a Legionella species out of our fountain out here a couple months ago. It wasn't a pathogenic one, but it was growing. It was growing in our little wonderful bubbly fountain. Yeah.
Well, that's why they were cleaner.
So if you were snorting that stuff, you could have gotten into it.
Letting your kids play.
Yeah, it's interesting, isn't it? That's actually a source. One of the Legionella is usually sporadic, but when it was diagnosed, it was at a Legionnaires convention in Philadelphia. That's where that happened. But then there were outbreaks in other areas of the country where they'd have some spray fountain in a mall, and these people all started coming down with inhalational pneumonia, which is a pattern of kind of a butterfly pattern, exactly what you'd expect when you inhale droplets. It'd be symmetrical. It wouldn't be one lobe or 2 lobes on one side, or small streaky infiltrate in the upper lobe on the left side. It would be like this butterfly pattern infiltrate, like you literally inhaled it. And so Legionella can be inhalational. Acute fever is inhalational because it's a dust exposure. And there's some others that inhalational, and the chest x-ray pattern really should tune you into that. And those are more unique agents. But normally when we treat outpatient ambulatory pneumonia, people with pneumonia, we don't do diagnostic testing. These are special studies that are done to figure out why the hell we picked these criteria and are they still working. So we go on to community acquired pneumonia in hospitalized patients. Now you see we're still the most likely is that we won't ever know the answer. Okay? Because you always see that, Tina, 486 is more common than 481, right? The DRG code for pneumonia is 486, means pneumonia unspecified. 481 is streptococcal pneumonia. We don't see that probably coded as much as we could. We could use the gram stain, we could use the urine pneumococcal antigen, but we will often do sputum cultures for hospitalized patients and then urine for pneumococcal antigen in hospitalized patients, because it's helpful to know. Sputum culture can be a little more helpful because why? Why is, if you get the antigen, you know they have pneumococcal pneumonia, why would a sputum culture be of benefit to you? I got to ask a non-microbiologist this. Carol, what do you think? What do you get with a sputum culture? If you grew strep pneumo, what are you going to get in the report?
You're going to get the positive organism.
And then after that, they'll report sensitivities. Yeah. See, you don't get that from pneumococcal antigen. And that's where, they talk about rapid diagnostics like PCR swabs. If you swab, why don't we just swab the throat or just take the sputum and do a PCR and see if strep pneumo's there? Well, it can be sensitive to penicillin, it can have intermediate susceptibility, or it can have be highly resistant. And we have started seeing, Connie's not here, but I think we kept tables, and I didn't include those today, but we can be anywhere from 7 to 14% of our strep pneumo isolates now are highly resistant to penicillin. That's really high. Now, most of those are in kids, and it turns out that hasn't correlated with treatment failures, at least in children, the way our pediatricians are treating them. And they're not using the vancomycin or other expensive antibiotics for them. So what that means is a little less clear than if you see 15 or 25 or 35% MRSA. That makes a big difference. But strep pneumo, that's not clear. The intermediate resistance is met with the use of ceftriaxone. That's why we pick ceftriaxone. But you want to know what you have, because if it's truly highly sensitive, you can treat them with ampicillin or penicillin and send them home. We also include azithromycin. Now, why do you need another antibiotic if penicillin is sensitive in the MIC? What do you think? What drives all that? Do you know that data, Tina? Yeah, and why did they decide that? Take a wild guess. What's that?
Was the study that they did?
They did a meta-analysis, actually. They took, I don't know how many, 6 or 12 studies, prevalent studies in pneumonia, what percent was causing this, and what the response rate was, and what the death rate was. And there's a hint in retrospective meta-analysis that if you combine azithromycin with, like, ceftriaxone or ampicillin, sulbactam, or a cell wall active agent, that you had less mortality. That's not intuitive that would work microbiologically. Back when we just had penicillin and tetracycline, it's clear that when you use tetracycline with penicillin, it interferes with penicillin's effectiveness. It causes antagonism. Tetracycline is a protein synthesis inhibitor, and so is azithromycin. So why, in heaven's name, does azithromycin potentiate penicillin cephalosporins, do you think? What's going on there? Do you think it's not likely to be its antibiotic effect, because they're both the same mechanism of action? And this is something that's not intuitive. Do you know what it is? It's an anti-inflammatory and it potentiates the immune response in ways that people are just starting to figure out, to the degree where there are people now recommending you use azithromycin even if you have a quinolone on board. And patients with cystic fibrosis are being placed on chronic azithromycin therapy. They have Pseudomonas aeruginosa in their sputum or MRSA usually, for which azithromycin has absolutely no activity whatsoever, right? But they don't get as sick as often. And it's probably the anti-inflammatory or, maybe some modulation of the excess immune response or potentiation of the appropriate immune response that makes that happen. And I think we'll see our current pneumonia guidelines evolve from what they are now, even because of that. And because of that data that's coming out, it's interesting. We understand so little about why azithromycin works, and for a long time, people thought that maybe it was just a fake, meta-analysis or retrospective is like the least potent statistical analysis you can get. I mean, it's fraught with hazard because the studies had different designs, they had different endpoints, they had different intentions, and sometimes there's secondary values that are not well collected that they throw in with primary values in another study, and it's a mess to do it. But that's often because they're so expensive. It's so expensive to do any studies. That's what we're reduced to, and it's kind of sloppy science. But in this case, I've had to change my mind. It appears there's more and more evidence that azithromycin is probably useful for reasons other than its antibiotic activity, which I think is kind of startling. It's startling to me. Not obviously anybody else. They haven't fallen out of your chair. And then for causes of communicard pneumonia in ICU patients, these are patients with severe pneumonia, unknown is still there. Which, hang on there. There we go. Unknown is still the highest. But strep pneumo has climbed up a bit, and now we're starting to see gram-negative bacilli, which include like Klebsiella, and then we're starting to see Staph aureus, which is oftentimes a post-influenza event, but now is with MRSA 300 and 400, it's a spontaneous event. And respiratory viruses can be mixed in, and H. influenza. Now, what type of H. influenza is this? Used to be. These are all non-typable now. Yeah, I think the biggest thing that happened in infectious disease, it was classically type B. I mean, that's the textbook answer, at least back in the day. But now it's almost all the untypable type. Why did the type B go away? It's a lethal, highly encapsulated, slimy bug. Phagocytes don't want to ingest it. You have to have a lot of antibodies and complement on it to make it sticky enough for the phagocytes, whether it's a macrophage or a neutrophil, to ingest it. So why has that gone away? It's literally disappeared
Because of the vaccine.
because of the vaccine, which is probably the most potent intervention in infectious disease in this country in the last 100 years. It's bigger than polio, I think. It just eradicated this disease from me, almost. I had one patient, he was about 87 years old, who went to visit family in Seattle. And he wasn't vaccinated, but most of us that were born back in the day are considered to have been exposed so much environmentally that we would have natural antibodies to have Haemophilus type B, right? But he had Haemophilus type B meningitis, just out of the blue, probably because of waning immunity. It's the only case I've seen in 20 years. It's pretty astonishing, and we saw it a dozen times a year in the first few years that I was in Butte. I still take care of 30-year-olds or 40-year-olds now who were, partly they had unrecognized Haemophilus meningitis from periorbital cellulitis as children that are neurologically impaired. I mean, I'm reminded of it every day in the office, but you're not anymore. I mean, in the everyday collection of data in our modern information system, that stuff is lost because it's not codable and you can't bill for it. Anyway, Staph aureus becomes a monster, and it's the worst. It can be as bad. Methicillin-sensitive staph can produce as many dangerous exotoxins as MRSA, but there is a newer MRSA strain we'll talk about in a minute called USA 400, as opposed to the 300, which is most of what we're seeing causing abscesses and skin infections. That's probably a little more invasive and more likely cause bacteremia, overwhelming sepsis, and death. So that's it. You see it? Oh, go ahead.
Do they give that Haemophilus vaccine to anybody but little kids? Do you give it to immunocompromised people?
That's a good question. There's poor guidance in the literature. The group that's most immunocompromised that I worry about is what group of people? What's that?
AIDS patients?
No,
Cancer?
no. They're missing something. Splenectomy patients. When you read the literature, they don't give you any guidance on that. They say you've got to get a meningococcal vaccine every 5 years. After that, everybody or pneumococcal vaccine, I apologize. Yeah, pneumococcal vaccine every 5 years. They're waffling on the meningococcal vaccine. The only group that's truly indicated, or absolutely indicated for now, medical legally, is freshmen going into dorms at the age of 18. Even if you're a sophomore in a dorm, they don't even think it's worth it. But I'm not sure that's true. If you didn't have a spleen, of course it would be. But how often do you repeat it? And if you look at the literature, it says you should repeat it every 3 years. I'll tell you, that happens in 1 out of 50 patients with splenectomies. So we haven't seen that occur. And you know that because there are many lawsuits about people failed to vaccinate. That's always what ends up driving some of this stuff. Whereas if you miss it, like happened with poor Bozeman Deaconess a few years ago, they got slammed and lost an enormous lawsuit over that failure to recognize the need to do the pneumococcal vaccine. For Haemophilus, you'd think the same thing for somebody, especially who hadn't been vaccinated as a child. I order an antibody, and it's a reference lab test, but I don't think most people do that. It's not a standard of care. I think it is. I think I'd want to know if I didn't have a spleen. I'd want to know if I had Haemophilus type B antibodies. And if I didn't, I'd take it as an adult. I took it, yeah. The pneumococcal vaccine is recommended at age 65. Do you know why it's at 65? Because that's what Medicare pays for. What age do you think you get the best response from the vaccine? 50, yeah. You get the best response from the pneumococcal vaccine at 50. The only reason we don't give it is because the government won't pay for it. So, a lot of what we do medically isn't science, it's money and politics, yeah.
How can we assume that that's good once somebody's vaccinated at 65? This seems absurd that their age, they assume they still have that immunity. Is that? I mean, that's just...
It's ironic, but there's never been a study to say if you measure the pneumococcal antibody panels, that it's a 23-valent vaccine, and the highest valent panel for antibodies you can get is a 12 or 14 valent panel of the most common serotypes. And nobody's ever correlated that even. And so they just came up with a recommendation to give it every 5 years. What Wyeth had, and now I guess it's Pfizer, is a conjugated pneumococcal vaccine for adults. And that data hasn't been published yet, but we'll know more when that comes. And their hypothesis was that if you got the standard vaccine at 65, which Rick is due for a couple of years if he doesn't fall asleep, and then at 70 you would get the conjugated vaccine and you would get a better response. There's some evidence the second vaccine at age 70 produces blocking antibody and you have less protection after the second shot.
I thought they said if you were 65 and you got it, then you didn't need it anymore.
Unless you have a compromising condition, which means what? What? Anything. Diabetes. Old age. I mean, gee, when is it really old age? 70? Nobody knows. Everybody gives it every 5 years. Nobody stops. I've stopped because of that data, but most of us are sort of forced. Because if you don't do it, the endocrinologist will, or the nurse in the ER will say, oh my God, he should have given you that shot. Wham, you got it. And then Medicare's happy, and JACO's happy, and is it science? Hell no, nobody knows what they're doing. But once every 5 years got out there, they're going to save 5 million lives, gosh darn it. Even if it kills 10 million to get there. I know, I'm going to say this every because the unintended consequences of some of these obligated procedures are yet to be analyzed very well. So it's good to be a little cynical about these things. I know. Well, these are the usual duration of findings in community-acquired pneumonia. People have usually been sick with a fever 2 to 4 days, cough 4 to 9 days, crackles, elevated white count, and it takes 1 to 3 days, usually more likely 2 or 3, I think, for a C-reactive protein. People usually won't present before this because they think they just have a cold. And this is just, I'm not going to go through this in a lot of detail, but there are a lot of classification criteria. And predict whether or not the patient's at risk for having problems if they are hospitalized. They're going to have complications that make you wish that you would put them in the hospital. Like the lady I saw yesterday, the office, she came in complaining of right upper quadrant abdominal pain. Right? How many people with pneumonia come in complaining of abdominal pain? What percent do you think it is? Remember the rule?
20 or 80.
20 or 80, right. What do you think it is? Geez, you're never that far off, 20 or 80. If it's 50, you're kind of close. It's 20. No, it is 20. 20%. Why do you think that is? What level, what dermatome is your belly button? Right, I'm going to make Danette answer this, though, because I think I told you. You're teaching these nurses, what dermatome from your spinal column, your sensory dermatome, which? Your belly button? T8. T12 is your inguinal ligaments. So T12, if you had a pleural irritation here, if you had a consolidated pneumonia with irritation of the visceral pleural, irritating the parietal pleural, irritating the sensory nerve, it starts up at T12 at the base of the lung, right? Comes down and goes down to your inguinal ligament. You come in complaining of pain like that. See, we forget those dermatomes are angled pretty severely. So a thoracic dermatome, so if you're complaining of pain, you have an enormous number of people have pneumonia and only complain, 20% will complain of primarily abdominal pain and fever. It happened here just last week in the hospital. They got a workup for a kidney stone, they got a workup for a gallbladder, and they had pneumonia and empyema. And he was in 309. And I'm not falling. It's really hard to sort it out, especially when they're kind of crabby and they're not going to tell you any of their symptoms. Why are you here? Well, why do you feel sick? Well, you're here to tell me that. When you get a patient like that, we're kind of stuck, so you got to remember your anatomy. They say this more often than you would ever think. How the heck, yeah, oh, you get one more question, Eileen. I'm kidding.
Sorry. With kids, we see an awful lot of kids that come in with abdominal pain, upper abdominal pain and then you do a chest x-ray and you find the pneumonia.
Yeah, well, that's what happened.
Real common. occurrence that you get the abdominal pain in kids. with
Right.
Pneumonia.
So you have to be tuned in, because it blew right by the first people that had maybe 10 minutes to do something before they had to clear the room out and get all the trauma. I mean, you know, you gotta be kind to people. We're all under a lot of pressure. But you also owe it to the patients to keep your ears and eyes open when people get admitted with presumptive diagnoses. And remembering that, I mean, that anatomy I always have to remind myself of. You know where those dermatomes came from? Do you guys know this story? This is a great story. The sensory dermatomes, you know, C1, C2, C3. Do you know where all those diagrams came from? How old do you think they are?
Grey's Anatomy.
Somebody pick a number. Somebody raise their hand and give me a number. Take a wild guess. 1800s? They're from the 12 and 1300s. You know who documented all those? So thousands and thousands of them, even though they didn't know what the hell they were because they noticed there was a pattern. Or these monks in France, in these monasteries, they would just take people's shingles and they just drew it. And those diagrams are the averaging of thousands of diagrams. They just overlaid and overlaid and overlaid and overlaid, and that's how because they didn't know what to do with them, and they didn't have any idea what they meant, but they knew somebody at some point would, and nobody has ever gone back and remapped those that I know of. I mean, that's a pretty impressive thing. So that power observation is where, I mean, I love that story. The person that had shingles probably didn't. So the lady I saw in the office yesterday came in with a cough, and she was crabby and had a white count of 16,000, and I get a chest x-ray, and she's having terrible pain from the shingles she had 2 months ago, post-herpetic neuralgia. So she's kind of splinting over here, and now she has more pain. And she kind of thinks she has more pain, but she's not really very specific, and she's crabby. She's a retired nurse. And I get a chest x-ray, and she's got it right in the middle of pneumonia. And so I said, well, I'd write the prescription, give her the antibiotic, give her some IV fluids in the office. They go home and take this right away. You probably should be in the hospital. Why did I say that? I had chemistry studies. What? No, she had a sodium of 126, which she's never had before. Those are the kind of complicating problems. This isn't included. It's in the second slide. But you know, coexisting illness, laboratory findings, sodium less than 130. She should have gone in the hospital. She refused. And so she shows up in the office this morning even more confused, and the white count hasn't changed. She never had a fever because she's close to 80, so sometimes patients won't have fever, right? Now her sodium is 123. What do you think she told me?
I want to go in the hospital.
I said, no. Oh, hell no. She still didn't want to go. I said, well, did you tolerate the antibiotic? She said, you know, I forgot to get it. And probably she forgot. She's not stupid, just because she's a little delirious from hyponatremia. And, you know, I'm stuck in the office just like people in the ER. You can only do what people let you do. When they absolutely refuse, I couldn't declare incompetent and call a county attorney. They'd laugh at me. You know, and I don't think she hasn't been in the hospital in 20 years. She's otherwise takes good care of herself. This is, you know, pneumonia probably came from splinting from the shingles and a little atelectasis and then a little pneumonia and then a little hyponatremia on top of a retired nursing personality, which is only outdone by retired physician personalities. But I mean, you know, I have as hard a time as anybody in the office when you see these sick patients. It's fine and good to sit in the classroom and talk about these things, but people don't care sometimes, or they don't know enough not to care. And you have to remember to stick to your guns, and I wish I had. Well, this is more of a typical pneumococcal pneumonia, what they would call a lobar pneumonia. And this patient had bacteremic pneumonia. That's one of the criteria that would predicate admission. When you have absolutely complete lobe involvement. How often do you have a positive blood culture in a pneumonia patient that's sick, do you think? Just take a wild guess. 20. Yeah, it's like probably less than that. It's probably 8 to 12, maybe, somewhere in there, 8 to 10%. If you had a sputum and they grew strep pneumo, and they gave you an MIC, and then the blood culture was reported as strep pneumo, would you want the MIC in this blood culture isolate? I mean, you already have one from the sputum, right? So why do you want it from the blood culture isolate? This is not information most ID docs know, but I know because I asked a stupid question and I was told why I didn't understand what I was talking about. So now I'm going to make you suffer. This is actually an interesting thing. This was studied very well in the 40s and 50s. It turns out when you're sick enough because of influenza or COPD from smoking, or you have predisposing factors, you're more likely to colonize with pathogens like strep pneumo, Haemophilus influenza. Now it's non-typable, Moraxella catarrhalis, Klebsiella. And the average number of strep pneumo serotypes in a vulnerable patient is 3. All of which could have, one could be sensitive, one could be intermediate, one could be highly resistant. You don't know. You want to know what the bug that got in the blood is sensitive to, because that's the invasive serotype. So you can be colonized with several different serotypes of these invasive bugs, and sputums are only a hint of what may be causing the problem lower down in the respiratory tract, because sputums are so often contaminated with oropharyngeal flora. If we're lucky enough to grow strep pneumo, you still have to be suspect of sputum cultures because you can be colonized. And below the vocal cords, the COPD patients usually are colonized. It's only in the normal host that you should be sterile below the vocal cords. Chronic obstructive lung patients are more often not colonized with strep pneumo, Moraxella, sometimes Klebsiella and other organisms chronically. So you get into sputum, all you know is what's colonizing their tracheobronchial tree. But if you get a blood culture, it's golden. I mean, that's the one you want to chase, the sensitivities. Because that's the one that got in, because of other probably virulence characteristics, which I won't worry with. And that's this typical sputum of strep pneumonia, these juicy gram-positive diplitoxins. I don't mean juicy, you'd like to eat them, I mean. And these are, what are these? Resin, what are they? Neutrophils. Why are they important? The gram stain shows you the bug. Why do we care about neutrophils?
Shows response of the body.
Yeah, it also shows that it's a good specimen. It came from down from the depths, right? And you don't see a lot of epithelial cells from the oral pharynx, you know. Large epithelial cells with usually small nuclei right now. So you want to have, they have criteria for that. A good sputum is greater than 10 to 25 and less than 10 epithelial cells per high-powered field. So the white cells are important because you know you got good bugs. And this is like a woman with bacteremic pneumococcal pneumonia, had a really dense left lower lobe infiltrate. Actually, the fissure between the left lower and left upper lobe is bulging because it's so much edema in the alveolar sac was just pressing on it. And lobar pneumonias are more likely to be bacteremic, and multilobar pneumonias are more likely to be bacteremic than just little patchy bronchopneumonias. And here are the complications of which we are still seeing. I mean, it's always amazing to me how we see it. I think we see as sick patients with pneumonia in April and May as we do any other time of the year. You know, you think it, in other parts of the country it's January, February, but you know, in Arizona now it's 75, 80 degrees. People aren't showing up with pneumonia down there, but we are here. And why it is with the weather, it's probably because we crowd in more, I think. I don't think the temperature has much to do with it. This is a lung abscess or narrow fluid level in the right lung here. When you see a flat line like that, that's fluid that is communicated with the airway, atmospheric pressure. So it's got to have connection out to the oral pharynx. When fluid layers out, that's going to be an abscess. And a CAT scan is better. You know, the faster we intervene and decorticate these people, the better, because if they progress to get necrotizing pneumonia, you'd have to have incredibly competent thoracic surgeons not to cause poor outcomes, otherwise known as killing the patient. So urgent, immediate decortication is now considered a standard that most of us would like to see. And these are just interpretive breakpoints for strep pneumo. These have changed a little bit over the years, but this just to stress the fact that with penicillin and extrapolates to other antibiotics as well, they could be susceptible to intermediate resistant. And if it's intermediate resistance, generally we're forced to use ceftriaxone or oral cephalosporins. And I'm not going to kill you with those numbers and all that. And you notice they include azithromycin, and what do we say? I mean, do we care about these? It doesn't appear that that's the important reason azithromycin is included. It's becoming more, that's just fascinating to me. And for patients that are admitted the intravenous antimicrobials for pneumococcal pneumonia, this is what the textbooks say, but you would also always include azithromycin. You know, people say, well, gosh, we can just give them ampicillin because that's what it's sent it to. But the outcome data in more and more of these studies is indicating that survival is better. Mortality rates are lower. You know what interval do you think? Since penicillin was introduced, what interval do you think? Is your time you're admitted to the time before we change the mortality rate with antibiotics? This mortality rate interval, the death in hospital hasn't changed in 100 years. First 36 to 48 hours. If you're going to die of pneumococcal sepsis, you're going to die no matter what we do. That's why they push the vaccine so hard. Because you can reduce that in-hospital mortality in that first 36 to 48 hours if you've been vaccinated. Vaccines don't reduce the risk of pneumococcal pneumonia at all. But they do reduce the rate at which you're hospitalized and whether or not you're going to survive it in the first 36 to 48 hours. It's not a perfect vaccine. It's not like Haemophilus type B. It's gone as a disease for practical purposes. We're still struggling with a good vaccine for pneumococcal pneumonia. That's an important thing to understand. Keep your eyes and ears wide open for newer vaccine trials, because I think these conjugating vaccines, like they use Prevnar in kids, the 7-valent one in kids, is the model we're going to see for adults. And then whether the government ever catches up with it, God help us. This is the chronology of mycoplasma pneumonia, and I love the slide, and this has been published. This is a redrawing. This is actually a slide from the 60s, where they talk about how long you can be ill with mycoplasma pneumonia. Mycoplasma pneumonia doesn't make you as fulminantly sick very often as pneumococcal pneumonia. It's almost always an outpatient pneumonia. And it's spread in family groups, but it occurs very sporadically. A man, one of the teenagers will get it on the 1st of February, and then the parents might show up in the first week in March with a cough and a funny infiltrate, and then, the spouse shows up 2 or 3 or 4 weeks later with the same sort of vague thing. It'll drift through a family with much longer incubation periods. And, if you're not treated at all, you often recover. And there was a lot of debate 20 or 30 years ago about whether we should even treat these patients. Why do you think that debate's gone away? We do treat them. Because we can't afford to do the diagnostics to find out if that's what it is. And nobody's ever shown that using macrolides, like back in the day originally, erythromycin or azithromycin, shortens the length of illness in mycoplasma pneumonia. But the reason we always treat is because we don't know if it's pneumococcal pneumonia. It's interesting, isn't it? I mean, I hope it's true, and anecdotally you would like to believe it's true, but then there's always the patients that cough for 2 or 3 weeks and the chest x-ray doesn't clear right away, and they have variable, the fever's going to respond within a week or 2 anyway. These are like 95th percentile, so some of the things that are listed as things you must do are partly because we don't know what the hell else to do and we don't want to miss anything that might be lethal. That's worth knowing. So here's a review. There's a postal worker that came. He had a history of recurrent pneumonia. His doc had seen him 3 weeks ago for a dry cough, fever, headache. Rowels in the right lung base. Chest x-ray showed a right lower lobe pneumonia. Treated with amoxicillin clavulanate for 7 days. But failed to notice much improvement. So his family says, you better go and get reevaluated. And another chest x-ray shows now he has right lower lobe and a patchy right upper lobe pneumonia. And so this is the typical atypical pneumonia, of which mycoplasma is one. What are the other two we talked about? Chlamydia pneumonia, and in which treatment probably is effective, by the way. And what's the other one that we don't see here? Legionella can appear this way, yeah. This is one of my medical student questions. Are they facultative or obligate intracellular pathogens? I mean, can they live outside the tissue in the human host? Mycoplasma, Legionella, or no? They can't. No, they're obligate. They're dependent on your cellular machinery to replicate. They can survive. I think that's what you were thinking. They can survive, but they won't replicate and cause progressive infection unless they can have access to the cellular machinery or respiratory tract. They're kind of unusual bugs. They don't have cell walls. They have cell membranes, but unlike other bacteria, with the exception of Legionella, they do that. So, but Mycoplasma and Chlamydia, Chlamydophila now, don't have cell walls. So his white count's 11,000, and he has cold agglutins, which used to be the thing. I did that all the time on the floor when I was admitting patients as a medical student. You take the serum, and you take the blood and spin the serum, and you put it in the refrigerator in an ice bucket and see if it clumped visibly. It's pretty simple. Makes Randy shudder. So do you think this helps us separate mycoplasma from other causes of pneumonia? Any idea? Does it help you with mycoplasma versus chlamydia or Legionella? It does, yeah. We don't do them now because it's a reference test. Take 48, 72 hours to get the report. If you had medical students, slave labor. Actually, we do have nursing students. Maybe we should make them slave labor. But you could do those, and that would be helpful. And you know, it will be more likely than not mycoplasma than chlamydia or Legionella. If it's cold, Legionella isn't associated with a cold agglutinin response or proteins that clump in the cold. This is a pretty empiric observation. But what respiratory virus does that as well that you have to worry about? Influenza. So, you know, some of these diagnostic techniques, I only bring this up because we used to have some diagnostic techniques. We think, oh man, we have cold agglutins, it must be mycoplasma. We're not sure whether it's going to work, but we can treat it. Well, it turns out influenza, the influenza virus can trigger the same response. So our diagnostics have gotten better, and that's why we use rapid diagnostic ELISA assays now, looking directly for the antigen and not looking for the host response because it's a little bit overlaid. So this patient could develop a diffuse macular papillary rash with target lesions and ulcerations in his oropharynx. Is the infection going to his skin? What do you think? No. What is it? It's called what? Stevens-Johnson syndrome. Yeah. It's just it's an immune response, and I think Randy has told me in the past, an IgA mediated response. Isn't that right? I thought we had talked about that. It's like a leukocytoclastic angiitis on post-capillary. I can't hear a goddamn thing you say. Sounds profound, I'll agree. No, do you remember? I don't remember the.
It seems like last time I looked it up, I'm thinking that there can be complement or IgM in this along.
Yeah, it's poorly understood, but it causes these classic lesions that look like target. I'm going to rock here because I'm talking too much. So here's a case that was actually a medical legal case that I think is worth putting in your bread basket and remembering, because this was a case that actually occurred in the Billings Hospital. Smoker, 70 years old, chronic obstructive lung disease, came ER with a history of increased cough, fever, low back pain for a week, had an elevated white count. They did an x-ray, right middle lobe infiltrate. They thought it was pneumonia. They couldn't get old x-rays. Long-standing heart murmur from aortic sclerosis, which 50% of people over the age of 60 have, right? So what do you do with that? Hard to know. Given a gram of Rocephin within 6 hours of signing in, right? Medicare's happy. Are we all on the same page here? Government's happy. sent home with instructions to use his nebulizers and call the ER in the morning. Next morning, gram stain shows, you got a good gram stain, it's got a lot of white cells, doesn't have any epithelial cells, 4+ gram negative coccobacilli. So what do they think this organism is? Don't read ahead. They think it's Haemophilus, H. influenza, non-typable, right? Because that's the most common cause of pneumonia if it's a gram-negative coccobacillus in a chronic obstructive lung patient. Is the typing important? It's important because if he had type B, he either didn't get an immune response from exposure, wouldn't have had any reason to be vaccinated, or it could explain rarely patients with hypogammaglobulinemia. If you have lost your IgG, which is a rare problem but can happen, you could get Haemophilus type B because you could have the vaccine, but you don't have any antibodies to respond to the vaccine. Or they can remember that you had the vaccine. The plasma cells aren't there producing that IgG. That would be rare. That's not this case. Blood cultures are positive, and Haemophilus or Haemophilus. Stop right there. What's wrong? Diane. What was the cause of pneumonia we thought we had? Haemophilus influenza. Yeah. This is only one of the great mistakes that gets made clinically is when the lab reports atypical organisms that you've never heard of before. There's probably a reason they bothered to say Aphrophilus. Otherwise, they would just say Haemophilus species and let you go down that Medicare algorithm and praise God, pass your JCO review, and everybody's happy, right? But when the lab throws you a hooker like that, they're not trying to be smart asses. They really are giving you information that should make a difference. And where does that bug come from? You know? The oropharynx. It does not cause pneumonia. It has never been described to cause pneumonia. However, it does have a great affinity for heart valves, and it is a well-recognized cause of endocarditis. When you see something that isn't familiar, Haemophilus, Aphrophilus, wait a minute, Pullman said strep pneumo, unknown strep pneumo, Haemophilus influenza, maybe Moraxella catarrhalis, maybe Staph aureus, maybe Haemophilus, Aphrophilus. There's a reason they do, because there's a natural history for this. A positive blood culture for this organism is an infected heart valve and too prevalent otherwise, and it virtually always is an infected heart valve. But this poor guy stopped right at Haemophilus, didn't think what it meant, gave him a gram Rosuffin daily for 3 days and sent him home on an oral cephalosporin. And 1 month later, he came to the ER with fever and chest x-ray, blown out his valve, had to go for a valve replacement. I mean, I just say this because, you know, you get a little bored hearing these organisms and you think, oh, blah, 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 Haemophilus, what, Haemophilus, Haemophilus. You know, you just, but really, Aphrophilus is really unique to the oropharynx. One of the surgeons, spinal surgeons in Bozeman, called me up and said, "Oh, I got a patient I did a fusion on a month ago. Pus draining out of his wound all of a sudden, fever, redness. Cultures it grows Haemophilus, Aphrophilus." What did I tell him? That he didn't get his prophylactic antibiotic on time? No. It's not a blood culture, so he doesn't have endocarditis. I'll give you that word. How do you get it? I told him. I said he has a tooth abscess. And then he says, oh, BS. You know, what does that mean? He thought I was messing with him at this point. I said, he doesn't have any pain. If you have a tooth abscess, you have pain, right? No. If you've got a root canal, you can get an apical abscess, you won't feel a thing. And he did a Panorex film on the guy. He had a 1.5, 2 centimeter periapical abscess on one of his molars. Absolutely silent, but pus under pressure will cause bacteremia, and he seeded the operative site. Astonishing. Now the poor guy, every patient he has to go to a flipping dentist. I'm not kidding. Anybody that's had a root canal has to go get a Panorex at a dentist. He's not operating on you. Get out of here. But paying attention to those bugs and knowing why that's different than Haemophilus influenza, knowing the natural history of what these bugs do is a huge part of what you have to deal with. So these are, what makes you go to more expensive testing? When you're going to do blood cultures, sputum cultures, and more expensive like PCR tests, it's when you're in the unit because you don't always have a lot of room. They're going to get sick and die on you as often as not, and despite what you do, unless you really pick the right antibiotics. If you fail outpatient therapy, we probably are pushed to do more diagnostics. When you have cavitary lung infiltrates, you're gotten away from strep pneumonia now. Now you're thinking of Staph aureus. Could it be reactivation TB? It gets very complicated. Active alcohol abuse, because you start to see gram-negatives like Klebsiella, and you have to expand your coverage from sometimes ceftriaxone now because of the problems with resistance in Klebsiella. So, there's all reasons. I'm not going to go into all that. I think we cut a lot of this. I'm going to hurry. And then this is sort of a bioterror slide. I'll let you just look at it at your leisure. I mean, this was back when the government was paying, hundreds of thousands of dollars to people to rattle off these silly slides. And we have a case we'll talk about at the end that fell in that category. And these are the guidelines from the IDSA and the Thoracic Society for empiric antibiotics for outpatient treatment, macrolide or doxycycline, inpatient treatment, a fluoroquinolone right now, or beta-lactam plus a macrolide. And for ICU patients, then, because you're worried they may be an alcoholic and you haven't figured it out yet, you've got to cover organisms, or they're COPD patients at risk for gram-negatives that are resistant, then you have to start covering Klebsiella and Pseudomonas. These are all pretty standard algorithms. I'm not going to make you walk through because you've got to cover a lot. And so for specific pathogens, again, you have to be a little careful with these recommendations because of the evidence that the combination of azithromycin gives you better survival and less mortality. But those are all things you can look up. Any question on community-acquired pneumonia? I mean, I could bore you with reciting all those combinations, but they're pretty standard. The thing you have to remember is that in the influenza season, you have to worry more about Staph aureus, and so when you're put in the ICU, anybody in the ICU, I think, should be covered for MRSA pneumonia until you know they don't have it, because it's too lethal if you miss it for 48, 72 hours. And so and if it's a COPD patient at risk for Pseudomonas, you want to extend it. So you may have azithromycin and levochlin, but you probably also want to have piperacillin, tazobactam, and/or ceftazidime, and/or carbapenem to cover Pseudomonas. And you want to have a carbapenem if it's Klebsiella because of what? What mechanism? Resistance. Rizik, I'm looking at you. I can feel it coming. Yeah, the ones that produce the extended beta-lactamase producers. So let's go to acute bacterial skin and soft tissue infections. Natural history is really important. This is one of the most overtreated infections in the ER that we see in terms of the number of antibiotics that get ordered. They usually get 2 or 3 different antibiotics because they look so damn sick, and then they get sicker the next 24 to 48 hours. And we'll talk about that. And then we'll talk about the treatment guidelines, which are a little less formalized as they are in pneumonia. First, we'll do a bunch of quick presentations. 19-year-old woman comes in with a 5-day history of sore throat, painful swollen anterior lymph nodes, so it's not mono, it's not going to be that rare Leydig disease, right? And this fluctuated lymph nodes aspirated. What's that? That's the microtext, you got it. Gram-positive cocci and change. That's a strep, that's some form of strep. And it's strep pyogenes from a neck abscess from a severe pharyngitis. And that's not a common complication of strep pharyngitis. It's not unheard of. And then there are people who worry about the use of beta-lactams in suppurative pharyngitis where there's localized areas of low pHs or an abscess in the neck with a low pH because what? You use penicillin or amoxicillin. Why does that? Diane, I can ask for you. This is something that a lot of people have forgotten. Because beta-lactams are not very active in an acidic environment. If the pH of the fluid goes from 7.4 to 7.3, the MIC goes from 0.5 to 5.0 goes up 10-fold. So if it goes to 7.2, the pH goes up 100-fold. If it goes to 7.1, the MIC goes up 1,000-fold. So it's exponentially related. And so there are people who feel when you get a streptococcal abscess, if it's not adequately drained, you should be using an agent that isn't sensitive to pH like clindamycin. Just, I mean, it's important to remember. So here's a 59-year-old redness, tenderness, and the fluctuation of midline incision 6 days after sigmoid resection. Foul smelling, sent to the lab. What's that show us? I asked the microphone. You can do it. What's this? Gram-positive sort of cocci. Chains, right? What are these? And then there's other fat gram negative. There's a lot of different bugs in this. So what is that most likely from? What kind of source, since they operated on a colon? Oh, yeah, these people. These are fecal. I know we can talk about common things and it gets boring, but you know, you think this stuff, if they grow beef rats and E. coli, you think, oh, you know, sure, it's fecal organism. We had a patient that was an auto-inoculator who would take feces, and I don't know how she did. She injected them, and we would grow E. coli, bacteroides, just fecal organisms. And people would look at that, and you know what they thought? She had septic arthritis. It was open and drained. They thought it was skin contaminant. You got to work at contaminating your skin with this kind of stuff. I mean, this many organisms that well. So in the rare, I mean, it's worth, microbiology is important to know, but you also have to know the context. You know. It doesn't infect joints. Stool doesn't go to joints unless somebody injects it. It can go to skin if it's contaminated post-operatively. So you see fecal organisms in the skin wound after colon surgery, it's one thing. You see it in the knee, that's not the natural history of a post-operative wound infection or a spontaneous infection. It doesn't happen. Those bugs don't migrate through the blood. Your stool doesn't migrate to your joints, thank God. And there was an abdominal abscess underneath the wound, and there were 3 different organisms in this one. Here's a 55-year-old with a less than 24-hour history of right leg pain with large blister swelling and severe edema. Sorry, it was 1 a.m. in the morning, and the E's were getting thin. She was hypotensive, tachycardia, obviously septic. They aspirated blisters for stacked gram stain. So who do I call next? This is the next phone call I make. No, I don't care about the gram stain. Not here. Yet, I do. Yeah, and we will. You're right. Who do I call if I'm looking at this patient in the office of the ER probably? A surgeon. This is a surgical disease. This is Clostridial myonecrosis. This is, you better cut it off or it's going to kill her. And the patient I saw here, and the slide isn't from that patient, was back when I was at Apollo. There was a woman in upstate New York who was living in a house with a dirt floor, and her toenails had gotten, so obviously she was cognitively impaired. The toenails had grown so long, they'd grown all the way around and into the bottom of her feet. And so she got soil contamination, and she showed up and was sick less than 24 hours and was dead. Just dead. You can't, and they, you know, they took off, they did a high above the knee amputation. That wasn't enough. They took her right to the OR. But this is the gram stain. It shows these fat gram-positive rods that are typical of Clostridium perfringens. And, you know, in the case they used here, it was from an intravenous drug user, which is another way you can get Clostridial myonecrosis from contaminated injections. And this is what it looks like in the blood. Hydroplate, it looks hemolytic, which is more typical of group A strep, or group C strep, or group G strep. I think they're kind of cool. And this is a biopsy of Clostridium in the muscle. It's causing myelocrosis. How are we doing this? Yeah, I can't believe I'm talking. Anyway, 28-year-old guy presents with pain, drainage, redness, swelling of the finger, scratched. Actually, he was bitten 3 days ago by his cat. So they aspirate the fluid, And after you drown the cat, what 2 people do you call? I've had patients readmitted 3 times with this infection from the same flippin' cat. I'm not kidding you. I just,
Call the veterinarian.
the dumb one, obviously the cat, the cat's not dumb. What 2 people do you call? Animal control, sure, why? Because aside from a bacterial infection, you've got to worry about with a bite especially. Rabies, sure. You want to make sure this isn't a rabid cat. Because I didn't say anything about, you know, how crazy the cat was. Rabies is back too. There's a reported case in Michigan. 9 months after the exposure, a guy died of rabies. He was asymptomatic for 9 months. He woke up in the bed, found a silver-haired bat on his arm, didn't get bit, just threw the bat off, and 9 months later was dead, presented with classic rabies, hypersalivation. No, because it's genetically they tag the DNA to the silver-haired Mexican bat. The rabies carries with it the genetics of the animal that it came from. So it sort of carries it along. So you know whether it came from a skunk or a Mexican silver-haired bat. So that's not uncommon, especially over in deer lodge. I don't know why in deer. I've had patients several times have those Mexican silver-haired bats. They probably have more timber over there. And those bats love that tall timber. And those Mexican silver-haired bats, you don't have to be bitten anymore. Just the proximity in the house or a bedroom is enough to require. Because we don't know whether it's aerosol spread now or not. But in this case, it wasn't rabid. It was, you know, a cat. And who's the other person you call? This gram-negative coccibacilli. He's got pus under pressure in his finger, which is a fairly contained space with a lot of a lot of spaces. Surgeon, sure. Pasteurella meltasa. It's common. It's a normal organism in the mouth of a cat and a dog. But a cat bites worse than a dog bite. You know why? Especially on the hand. Because it's sharp. Sure, and more likely to go all the way down and pierce the periosteum, the lining of the membrane of the bone, get underneath that, or the tenosynovial sheaths, you know. And then it's in a closed space with no blood supply, and it just rips up your hand. They had a trapper, and this was 20 years ago. I'm not kidding. Before anybody talked about resistant gram-negatives, he died of a multiply resistant, virtually pan-resistant Pasteurella meltasa, spontaneously occurring from a bobcat that he had caught in a trap that scratched him and bit him. Guy died of Pasteurella sepsis. So why does Pasteurella have resistance when obviously the bobcat wasn't even getting antibiotics, even though he was in Missoula? Somebody thought they would have if they thought it would have helped. A lot of these resistance patterns, we'll talk more about at the very end, they're occurring in nature all the time, and they often have nothing to do with antibiotic resistance. They often have other metabolic consequences that favor the organism in its environment, in the mouth of the cat or whatever, right? So just because it imparts antibiotic resistance doesn't mean that that's the reason it exists. This idea that all antibiotic resistance is driven by human behavior is known as mammalian chauvinism. Because you know what the biggest biomass on the planet is? At least the source that I read. What do you think there's more of? What class? Fungi. Fungi outweigh everything. What's the second biggest biomass? Bacteria. Sure. 2 biggest biomass. You know, we like to think we're the center of the universe. We're probably a cosmic joke, but aside from that, the interface between fungi and bacteria is enormous. They're constantly. And where did our original antibiotics come from for the most part? Fungi, because they're always fighting a war with bacteria at some front, at some interface. When they dug up that sailor in the Antarctic, and he had been left there in, I think, 1895, they cultured his intestinal contents. He was virtually freeze-dried during a lyophilus. They found ceftazidime-resistant citrobacter in his bowel. And, you know, he was 80 years from being exposed to ceftazidime, 70 years. Well, that mechanism that imparted resistance is there for other reasons. So you can't always anticipate, even though it's kind of a natural exposure from a cat, or even if it was a wild animal you trapped, that resistance isn't always because you come from a nursing home and the family doctor is worried too much leave for you. You know, it can occur naturally, and you gotta be tuned into it. So here's another one. 32-year-old comes in with a history of buttock abscesses, 4 fluctuant plurals, 3 4-centimeter plurals are found in aspirated. What's that organism? Did not give me a wild guess. Julie knows all these. These are gram-positive cocci, and they look like clusters of grapes, right? Classic staphylococcus. Lots of white cells. How do you manage these? What do we do? We've got butt pus, right? That's what we call it. Drain it. Do you need to give antibiotics? Why not? What's in this information that it's been shown actually in a number of studies to be adequate in making resolve spontaneously if you're incise and draining? What did I tell you here? Somebody said it. Is that Chris? Did you have the answer? Just saying you're bored and want to get out of here? Man, kidding. It's the size. Less than 4 centimeters, less than 5 centimeters. It's been well known. There's a guy at UCLA named Chip Chambers who has done this on thousands of patients. And so you're very safe incising and draining, and if they're less than 5 centimeters in diameter. If they have erythema that's more than 5 centimeters around, then you're obligated to treat. But an isolated boil, incise it, drain it, get the pus out, do it. You don't need antibiotic therapy. You believe me? Chip Chambers he's a surgeon, of course, so you got to be a little skeptical. So why do you have butt pus? Why is MRSA causing so much problem in the butt and lower abdomen? How come we don't get it all over our heads and on our arms? What? Did I hear that? I know you can't answer it when you know. That's because but she's right. It's colonizing the colon. And why do people have recurrent buttock abscesses when they're given doxycycline or Bactrim? Because there's nothing left of those antibiotics when they get down to the distal colon. They've all been designed to be well absorbed, to give you good blood levels, to give you good tissue levels, except they don't go back into the stool. And so you haven't cleared your rectoperior state. And you'll never see a study that shows this, because getting informed consent for rectal swabs is proven to be virtually impossible. Lots of us, you can swab your nose till hell comes home, even maybe under your armpit if you remember to use your stick that morning. But you can't get patients to agree to rectal swabs. And besides from the swabs alone are not very sensitive, you usually have to go stool. But how many times do people call you up and say, there's 4+ Staph aureus in the stool, what do you think was mean? Is that why you have diarrhea? No, it's because he's colonized there. It's just, that's where it's carried. MRSA at 300 and 400 especially. Here's a web ball. This is usually from a break in the skin, often of a healthcare worker, sometimes not. Who, in the classic story, was exposed without using gloves to secretions. Because herpes simplex, 95% of us have it by the age of 5. Herpes simplex. And when you're stressed and sick, you shed it. If you're not stressed and sick, you shed it 4 hours a month. Whether it's herpes 1 in the mouth or herpes 2 in the genital area, or herpes 1 in the genital area and herpes 2 in the mouth, doesn't matter. They both behave the same. The rest is Victorian insanity. You shouldn't care about it, right? But if you have a nick in the skin, you get exposed. And if you're under stress, like the ICU patients are, over 50% of them, you could get a positive herpes simplex swab if you just swab your cheek. So that's why we want a glove when you're suctioning secretions and so on. Because if you have a nick in your hand. And then if you treat it with this aclivir, and it goes away, or if you have a nick on your arm, there's an ICU nurse in this hospital that has one on her arm, and it recurs every 3 to 5 years, just like a cold sore on her. an ectopic exposure from scratch. Yeah,
I'm curious, so you're, some people, like you said, 95% people get exposed to someplace.
they're infected with it. It's in the DNA of your adenoid tissue. Ganglia, yeah, that's right.
And so some people get cold sores, throughout their life.
Right.
So I get exposed to the sun, I'll get one on my lips.
Right. Some
Other
don't.
people, they might get one and then they never get them the rest of their life.
That's right.
Are they still carrying them or do
Absolutely.
they have some immune response that kills them?
They just don't, why they get the active disease, but even the ones that don't reactivate shed 4 hours a month. Doesn't matter.
They never get a cold sore?
They don't have, they still shed. They still have it in their ganglion and they still shed it. Yeah, that's the part that gets lost, and that all came from the STT data. Because they looked at and noticed that people were shedding it 4 hours a month, whether they ever had active recurrent genital sores or not. That's why it gets spread by asymptomatic people, because they shed 4 hours a month. And then they went ahead and looked back on the oral findings and they found the same thing. It's interesting. It's not why you get cold sores. I've never heard it. I don't think anybody has a good explanation. But it has nothing to do with the frequency of shedding. Except for the fact, I should say, when you get cold sores, you're really shedding high amounts until that heals. That's a high titer. It's not always a high titer in people that don't get active cold sores. But why the immune system of some people is so much better than others, I don't know. I've never heard of an explanation. But everybody sheds. I don't care who you are.
What about them?
Same.
So most people have to have these two and they shed virus, but
Don't have any recurrent. They don't have ulceration.
but they still have infection.
Yeah, in the ganglion, in the sacral. And women, young or old, the most likely presentation, sometimes the only presentation isn't active genital ulcers with reactivation of urinary retention from the involvement of the S1, S2 ganglia.
But when you do, people have that
Yeah,
is it not so much, okay, they got an infection, but much as there's something on the immune system that they
Can't
have
contain
active
it.
infection all the time and they're getting weak.
yeah, right. Whether it's stress or whether it's some other immunocompromised state, like patients on immunosuppressants, or HIV patients with CD4 counts less than 200, they have to be on prophylactic acyclovir, or they just have continuous cold sores. I know, it's very strange, but one of the patients that was most embarrassing is like an 80-year-old patient on the nursing home who broke out on both sides with genital herpes. She had and it presented not with vesicles, but as a long ulcerated, just red denuded area of skin on both sides, pretty symmetric. And we tried everything. We thought it was bacterial. We cultured it with Candida and Enterococcus. The state criticized me for not responding and treating the Candida and Enterococcus with the appropriate antimicrobial agents. They actually wrote me up on that one. I'm not kidding you. I love these guys. And the damn thing still wouldn't get better. And finally I thought, this thing is really, she said, it stings all the time. It's like stabbing electric shocks. I thought, oh, geez, what am I? So I swab it, and this was back when we did cultures, not PCR, and it was very simplex. I have an 80-year-old nursing home. What am I going to say she has recurrent genital herpes? The hell is going to break loose? The state's going to do an investigation for sexual molestation. It's just something that happened when she was 18, probably, hopefully. Do you know what I'm saying? But with the age and the decrease in her immune status, she reactivated. So what did I call it? I triggered it. I called it recurrent shingles. And they said, well, doctor, I know, when people say, can people get recurrent shingles? I say, very rarely, if ever. But I've heard you diagnose that on a number of people. That's why they're on acyclovir. You're absolutely right. I'm not going to tell them. Grandma had, good God. Those idiots from the state don't understand, what's colonization, what's not. And if I had let that sucker got out, I never sent her to the nursing home. I threw that report away. Put her on suppressive acyclovir, and she cleared up in that. but what everybody thought was a decubitus ulcer went away. I mean, you got to remember that Hummer can come back anytime. So here's a kid that comes, this last one, 19-year-old on home from, this happened, this is an actual case, and you're going to tell me the answer. On leave from Iraq, admitted to the hospital with fever. He has these purulent red lesions on both hands. And his epitropial nodes, which are lymph nodes that drain the hands, right? And axillary lymph nodes, and even his subpectoralis lymph nodes were huge. I mean, these things are huge. He's got a temp of 101 to 102, and he'd been on augmentin, moxonil laminate, for 3 days, because he'd gone the ER with these things, and you know, because it's expensive and he's a young kid, he'll probably get better no matter what we do. It's hard to kill 18-year-olds. Thank God. So, and it's simple. It could be just staph or strep from the abrasion when he was skinning the deer, right? You give him augmentin and he's not better. So, what are you worried about here? Lymphadenopathy, fever, exposure in a wild animal. The first thing the ER doc thought it was, no, not Lyme, plague. Yeah, they thought this was bubonic plague. And how can you tell? You don't know. It's a little unusual to have open ulcerations on the skin with it. Usually usually you just get the swollen lymph nodes and lymphangitis and fever and systemic response, right? But we covered him for that. And he wasn't getting better after 3 days. What did he have? What did I swab him for? What did I swab the 80-year-old lady with? Herpes simplex, sure. He's home on leave. He just came off leave. He's been in Iraq and shot at. That's one stressed 18-year-old. He doesn't have cold sores, but he is shedding. And he had nicked his hands when he was field dressing the deer and then auto-inoculated it, auto-inoculated his cuts. Those are herpes simplex lesions. White count was, 18,000. For all the world, he looked like he had a pyogenic bacterial infection. And he put him on, and his HSV PCR was positive, and I stopped his antibiotics, put him on acyclovir, and he got better. Herpes simplex will sneak in and mimic pyogenic infections. I got a panic call from one of the pediatricians a year ago. Same thing, 8-year-old girl walked in with one hand. She said, this girl has a necrotizing cellulitis of her hand, and I think it's necrotizing fasciitis, and you've got to stop and look at her. And I said, is she talking? Oh, yeah, she's fine. Do you have a fever? No, she's fine. She just said her hand hurts a lot. And I walk in, the kid has his ulcerations on just one hand, this little 5 or 8-year-old kid. And it was just a confluent, extensive herpetic whitlow on her hand. She didn't have lymph nodes, she didn't have fever or white counts, no, she didn't have necrotizing cutaneous gangrene. But she'd auto-inoculated a cut, some sort of split on her fingernail, and herpes simplex will cause those ectopic cutaneous lesions, and they are nasty and painful. And you're not always, and why one person gets sick with it and the rest of us don't, who knows? I don't understand.
Doesn't that make those people that get that do think like necrotizing fasciitis with kids with chicken pox?
Yeah, but that's because they colonize with the organism from organism. We can talk about that if we get to it. That's a good point. But herpes simplex doesn't tend to be colonized with superinfecting bacteria, and that's the interesting thing. Whereas if it was shingles, herpes zoster, group A strep and staph love to hop on board. So I'm just going to show you a couple of quick lesions. Erysipelas, the confluent pattern in the face, the same sort of erysipelas in the leg. And whenever you see a confluent lesion like that, it's a gram-positive infection. You don't have to get exotic, but you have to cover what? Not just strep and staph, but MRSA. So vancomycin alone would be adequate therapy for this lesion or this lesion. You will never see that happen unless I'm on the case, actually. Because it's really hard not to overtreat these days. It's just really hard, especially if you don't understand the natural history. And it'll get worse if you use just vancomycin the first 24, 48 hours, because you're killing all the bugs and all the toxins you're dumping in the tissue. Someone gets redder, the erythema climbs up the leg, the family says the next day, he doesn't know what he's doing, or the doctor says, I don't know what I'm doing. They add 2 or 3 more antibiotics just to be safe. Clindamycin, add a little peptazo, they're gonna throw it all in there. And then eventually it gets better, and then they think that they added antibiotics that help. And that would have evolved and gotten worse 24, 48 hours, and then would have gotten better if they hadn't changed the vancomycin at all. But it's really hard to watch this in these patients. It's really hard. And healthcare providers, we're all guilty of it. If you're in shock, you do have to add others, if we have time to go. Just take a break here. Just a moment to pause. I had talked to Phil about doing UTI in the next talk, and he thought that the repeater here was dying to hear about the treatment of UTIs now and not 2 weeks from now. Does anybody care? Can we do that? Because we can stop with skin soft tissue. Because this was more fun than I thought it would be. So Phil, nobody here cares. Even though you said there were people here that were only coming because of the
Never listen to
treatment.
me.
I'm kidding. He's going to the Bahamas. He doesn't care what happens.
Yeah.
So erysipelas, if you knew what it was, you'd use just penicillin if it was group A strep. But now with MRSA, it can also cause erysipelas. We're not allowed to use this unless we had a culture, and that would have to be usually a skin punch biopsy to show it was group A strep before you'd ever dare de-escalate your therapy from MRSA coverage. You would have to have a culture. You cannot trust it. And so some of these things you see written in the textbooks are a little bit tough. Let's just talk briefly about the options for treatment of MRSA, and then we'll quit. But right now it's clindamycin. Most of our isolates have actually become, we used to see more MRSA-resistant clindam, but now it's not. Tereflum sulfa, which is recommended, and this is 2 tablets twice a day, not 1 twice a day. 2 twice a day or 2 3 times a day. Doxycycline, minocycline. There has never been a study to show that tereflum sulfa is effective in MRSA therapy in a controlled trial, ever. It just seems to happen to work, or they're getting better on their own, but I don't like it as a primary drug. Why don't I like it? It's because it's bacteriostatic. And what's the other reason? If you're on it more than 5 or 7 days, you could easily have and get a rash, allergic reaction. Well, then if you get a diffuse red rash and you have a staphylococcal infection, what is it? Is it a sulfa rash or is it toxic shock? You don't know. That's why I tend to always stay away from that. And sulfas have a high rate of causing drug rashes. And so there's poor data. So I tend to use doxycycline or minocycline. And the only reason I don't use clindamycin is because it makes everybody so damn sick. It causes a lot of GI intolerance. And linezolid is only if somebody has a white count and fever and absolutely will not go in the hospital. But it's usually only invasive strains that trigger that systemic inflammatory response. You can get an awful lot of skin and soft tissue infection with MRSA, and I think we talked about that last time. But there's a clear different genetic loci that determine invasiveness versus the propensity to cause subcutaneous abscesses. Just because you get an abscess with MRSA doesn't mean you're going to be bacteremic. It's a small fraction of those MRSA isolates that have the genetic component that cause bacteremia and sepsis. And these are the parenteral antibiotics, and this is where we'll finish. Straightforward soft tissue infections, IV vancomycin, because it's cheap. And what is remarkable to me is that in 50 years of using vancomycin, we have seen so little vancomycin resistance. It's astonishing. And this drug is held up under fire. Linezolid is a bacteriostatic agent. You know where that came from? That wasn't found in fungi. You know where they found that? That was in a group of German isolates from DuPont that was discovered in the 30s. And somebody went back and they looked at 30,000 catalog compounds from DuPont, and they just tested them across the board to see if they had any antibiotic activity. This was a paint or a pigment. This was going to be used in the paint and pigment industry. And it turned out that just because of somebody that had the money to test these MRSA isolates, that they found it was active against MRSA. And it happened to bind ribosomes and prevent and block protein synthesis. But it was really a wild hair that found this one, linezolid. Daptomycin is an old one that got dumped by Lilly in the 70s because CPKs went up. But then when MRSA came back, they dug it out of the closet and looked at it again, sold it to a small company called Cubis, which is now worth a fortune. And it does cause CPK elevation, but it rarely is symptomatic. Unless you're on a statin. You can get severe rhabdomyolysis and renal failure if you're on statins and you have too high a dose of daptomycin. Especially if somebody with a BMI above 35 or 40 and you're dosing actual body weight, you can get into trouble real quick. So somebody on a statin should not be on, somebody on daptomycin should have their statin stopped. Telavancin is a combination of daptomycin and vancomycin that's been released recently, but has some of the problems of vancomycin and renal issues. And tigecycline was an antibiotic that was introduced as a tetracycline, or now they're called glycoglycines, sort of a third or fourth generation tetracycline that is active but only bacteriostatic, inhibiting protein synthesis for staph and strep, but also gram-negatives, not pseudomonas. It does have activity against Acinetobacter. But this is sort of fallen out of favor, especially with its use in intra-abdominal infections, because they saw an increased mortality rate. Do you know why that was, David? Because when the MICs are marginal here, and they got to, they tried 50 milligrams, it wasn't adequate. Tried 100 milligrams, sort of seemed to work. Tried 150 milligrams, what happened? In the preclinical trials, everybody vomited. Everybody vomited. The GI toxicity is too great. But that's the dose they probably needed, and that is because of the lack of adequate serum levels for a long enough period of time that I think most people think the mortality rate. So now they've come up with a derivative of tigecycline, which doesn't have the GI toxicity, which you can dose at 150 milligrams. Which study, Rick, who's left because he knew I was going to ask him, was supposed to have plugged in the computer so we could start the trial. Did he? Did he do it? Oh my God. He'll never catch him. Now we just had a patient die of complications of sepsis syndrome with an acute lymphangitis. She didn't have necrotizing fasciitis. But this is a little different than the patients who are not in sepsis or in shock. You really have to have cell wall active agents that are bactericidal. Vancomycin is currently the standard. Daptomycin is quite a bit more bactericidal. You get a higher log kill in 24 hours of dapto than even vanco. And if it's not in the lungs, it's a great drug. You need to use synergistic gentamicin with vancomycin. Nobody knows what to do with vancomycin. And the use of linezolid in septic shock or necrotizing fasciitis isn't because of its antibiotic effect. It's because it blocks toxin production in the organisms that are present. Because you can have 1,000 organisms per ml of blood, and vanco is still going to only knock it down to 10 or 1 in 24 hours. And so in that interval of 24 hours, those bugs are all producing the exotoxins that contribute to shock. And the use of linezolid is recommended because it blocks toxin production. It also has MRSA activity. If you knew it was sensitive staph, you could use clindamycin for the same reason. If you knew it was group A strep, you'd use clindamycin for the same reason. You use these clindamycin and linezolid in these, and empirically you've got to cover for MRSA, so we're stuck with these. Because you've got to block toxin production until you can reduce the organism load in the body. It takes 48, 72 hours. The use of PCR in sepsis is going to be most helpful, I think, when they do quantitative blood cultures. And I think in the next 5 years you'll see an increased use of PCR where they'll not only get a positive blood culture, they'll do a positive PCR in the blood and they'll quantitate it. And you'll draw blood at 12-hour intervals and see whether you're knocking down the titer of organisms. I think that's where we're going to see the use of quantitative blood culture analysis. I mean, this is 5, 10 years old. That's where the science is headed, and that's where the use of these drugs, we're going to be looking for drugs that are rapidly bactericidal. There's a poor gal that died, it was in, and she was recovering, and then had fatal arrhythmia from congenital heart disease. But it was the sepsis that killed her. I mean, make no doubt about it. And it's that first 48, 72 hours that's so hard to survive, no matter what we do, whether it's strep pneumosepsis or whether it's staph or strep sepsis. When you have a positive blood culture, even if it doesn't infect the valves, you're stuck with a minimum 14 days of IV therapy. Nobody knows what else to say. If you don't have a positive blood culture, how long do you treat for skin and soft tissue infections? Does anybody have any idea? If you do, you can win the Nobel Prize, because the FDA is still trying to figure out how long do you have to treat so that it'll clear and not come back. When the redness is gone, some people would get cellulitis, lymphangitis, their legs red for weeks. The FDA has been looking for some standard. They're looking at thermography, measuring the temperature of the skin. That isn't good because there's hyperemia long after the infection's gone. We don't have good measures on when to stop therapy unless you have a positive blood culture. We know it should go at least 14 days. We know the white count should be normal. We hope the CRP is coming down, but it might come down on its own if it's halfway from the peak. All these things are not even being looked at now. So there's an awful lot of clinical intuition and sort of experience that goes into how long we treat for these conditions. And when you're septic with fasciitis, the minimum is 7 to 10 days. When you have bacteremia, even if without sepsis, you've got to treat 14 days because of the concern that you'll have metastatic infection. It'll set up in a joint and a disc and recur if you don't treat it. Okay, last case, and then we'll quit. This is two cases. This is two unusual skin infections, both of which we've seen here. We've seen at this hospital. This is just an example of what they call lymphocutaneous sporotrichosis in the right lower extremity of a young man who turned his dirt bite over inoculated soil. So it was a soil organism. And then he had plastic surgery, and all these lesions formed on the edges of his skin graft, and it was a soil fungus, a yeast. And then there's the bacteria tularemia, which is also a bioterror agent that causes focal skin lesions and regional lymphadenopathy. You see his pectoralis lymph node swollen here? So this is, how do you tell that from this? Lymphocutaneous sporotrichosis doesn't always, they're very similar. They're very hard to tell clinically apart. I know they look a little different in these pictures, but these open ulcerating lesions, regional lymphadenopathy, could be tularemia, could be sporotrichosis. So, these 5 guys from the U.S. Fish and Wildlife Service showed up in my office at 5 o'clock one night. They've been up in Fort Benton, and they developed lesions like this. One guy had it on his cheek, one guy had it on his butt, the other guy had it on his shoulder. And one guy had a daughter who he kissed and hugged, the guy with the cheek lesion, and she developed a lesion on her cheek. And I don't know who they saw in Great Falls, but they went down to see a dermatologist in Bozeman who looked at them. I'm not giving you any history of exposure yet because I want you to tell me how they got it. And send them over here. So what did I do? You can look at the picture and it's not going to tell you, right? So how are you going to find out whether it's what's the first question you ask somebody that has this kind of problem? Swollen, ulcerating skin lesions. First thing you want to know is the history. But when you examine them, you also want to take into account the fact, do they have a fever, do they have a white count? Normal white count, no fever. Now, even in ulceroglandular tularemia, you don't usually get a fever or white count. So that's not going to help us here, right? So they work in wildlife refuge. They could have been exposed to anything, right? What did they do? Do you guys know this story? Well, what did I do? I didn't know what I was doing. I went to the pathologist. I said, what do we do? He said, get a biopsy. Great. So we biopsied the lymph node, and that gave us the answer. They had sporotrichosis, which in the ID literature is never described as being transmitted by contact with humans. In the derm literature, it's all over. But ID people don't read derm literature. Kissing lesions and cutaneous sporotrichosis is like old news. Dix and Robeson go to sleep while you're talking about this. Everybody in the ID world, oh, gee, no, that's the first time we ever heard of that. Right? But what were they doing? They had to build goose nests. Because they're at the Fort Benton Wildlife Refuge, right? On those little islands, they had to go put the straw out, and are they gonna spend money on good straw? No. They buy the cheapest straw they can get, which is all moldy. So, one guy, they had to unroll the straw bale, so one guy was pushing it with his jeans in this, and it stuck through his pants and inoculated his butt. The other guy was pushing like this, and the other guy was pushing like that, and his cheek against it. And they all got inoculated by the molded hay. Pretty wild stuff, huh? Wild stuff. And this was, now this is the part I'm embarrassed about. This was long enough ago that we didn't even have itraconazole or ketoconazole. So what did I treat him with? Do you know? The student should know this. This is historical. Hysterically historical. You know this? Potassium iodide. You know, you use potassium iodide, you have to treat them for weeks and months. I mean, it's very difficult. You don't know, you trigger hyperthyroidism and thyroid storm and all this other crazy stuff. Now we'd use itraconazole with them for a limited period of time. But that, you know, those guys, I could not have thought to ask that history. It never would have occurred to me. I just, it was too big a leap. You know, they do so many things there. They're dealing with dead animals. They're dealing, you can get any history you want from these guys. You know, but that was the one, and it was because we did a lymph node biopsy. And what stain did we do? Who's going to tell us how this? Who's going to do these stains now that our histologists are gone? Do you have people who do this? So who's doing it now? Anybody here? What stain would you do to look for spiral trichosis? I think I remember. It's a silver stain, man. They're rare. I think Dave Repla read them. It's so hard to see them that it's almost impossible to make the diagnosis, it turns out, on histology, but our pathologists do. They're so rare. These are immunocompetent adults. So we biopsy the lymph node. They're hard to find. It grew eventually in that part. We did, is it a Giemsa? No. What is that silver stain? What is that? Randy, do you know that? Yeah, methylamine silver stain. See, which stains black, and you see the yeast forms are black from the methylamine silver stain. Then we know what to do. But you'll see patients like that, and you can get all excited, but if they really don't have a fever or red streaking up their arms and stuff, you got to step back for a second and say, whoa, you know, strep and staph, they wreak havoc. They trigger a pretty intense response. Not always, but, you know, the rare exceptions for group A strep is erysipelas, that lesion, and sometimes MRSA can cause enormous subcutaneous abscesses, and they'll have a normal white count, and they all want to go home. And they'll have 75 square centimeters of erythema and, you know, focal areas of purulent drainage, and I don't feel sick, you know, so the triggering of systemic responses sometimes help, sometimes doesn't, but pyogenic infections were the exceptions. Those two exceptions are usually a lot more likely to give you fever and high white count and pain. These guys didn't have a lot of pain. It just scared them because they were ulcerating and they're swelling and they're spreading it to their kids. And they didn't have a clue what it was. But in the most part, when you see a severely painful lesion, they tell you it's like shocks, then you worry about nerve involvement, and then makes you think about herpes simplex, you know. Because it can look just as nasty on a little picture. And if the parents are in a panic and the healthcare provider's in a panic, you really have to take a deep breath, you know, before you call a surgeon, because the last thing you want to do is debride a hepatic lesion. So the last lesion you never want to debride, and I'll stop, is a common lesion here in ranch kids that are calving. When they stick, especially the ones that, when the calves have scours, diarrhea, they have to put those tablets on their mouth, and they don't carry around the thing because they're tough and they're teenagers. So calves have two top teeth, right? So they'll open the mouth and then they'll take the tablet and they'll shove it down into their throat. And then when they pull their hand back, this is always where it is, they scratch and inoculate their hand. And they get these huge, nasty looking, swollen skin lesions, bullous lesions with little erythema around them. And they last for 4 to 6 weeks. And the worst thing you can do, their grandmother will tell them, is go see a doctor. Because every doctor you see is going to want to open it. And if they open it, it streaks right up their arm. Do you know what it is? Somebody who I haven't told, don't tell others. Do you know what that is? It happens almost every year in calving season, it's a Sunday. It's cowpox. It's cowpox, sure. Do they ever get it again?
No.
Grandma will tell you, they never get it again, because that's Jenner's milkmaid. So when we were doing the smallpox vaccine, we talked to these guys from England, because only the English got the vaccine money, because nobody in the US wanted to put up with the legal expense of doing smallpox vaccine trials. And when we asked the English people, I said, well, what are you going to do about the people that have been exposed already to cowpox? You know what the Englishman said? That only happens in England. I'm not kidding you. He said, you don't have that in America. That's how ignorant we are of what goes on in other countries. It's fascinating, isn't it? They don't know what to do. But we know if there's a smallpox outbreak, there are going to be a few teenage ranch kids who were, you know, just because they were maybe smart, maybe stupid, kind of depends. Cowboys, that phrase speaks for itself. That got auto-inoculated. They're the milkmaids of Montana, that's what I call them. I said, geez, you're the milkmaid of Montana, of course you know. That goes over there. Okay, so we'll do UTIs next time, along with bacterial meningitis. Does that sound okay? Because I think otherwise we get off more than we could chew. Okay, that's it. Anything until they get hydrated, and then the injury in the lung fills with fluid, and it's that white fluid in the lung that gives you the diagnosis of pneumonia. But you can meet the admission criteria for pneumonia with even hypoxemia and a quote normal chest X-ray if the patient's severely dehydrated. So that's important to remember. And then clinical findings and lab data can help assess severity of pneumonia in the setting and outpatient or inpatient care. Oh, there's a soft pitch. That was a Chris Darby question. True. 70% of pneumonias will have a definable organism. Well, okay, that's important. And antibiotic coverage for initial therapy is impaired. True. Actually, it's hard to de-escalate now with that azithromycin data. It's really getting tough. We'll go to the next page. True, false. MRSA can be distinguished by MSSA by gram stain of infected tissue. Lab techs can't answer this. What do you think? Do you think it can? It can't. Only by PCR, which nobody is buying anymore, but some hospitals bought before the crash. And I don't know if we'll ever get it here. And I didn't get to talk about this, but the USA 400 strain, I think I did, yeah, is more virulent than the USA 300 strain. That's true. Yeah, I didn't really explain that clearly. That's a strain that came out of Detroit. And Detroit thinks that they're the birthplace of MRSA. They do. I'm not kidding you. The ID docs at Henry Ford are insistent that that's where they came from. Just historically, because they saw it first, and they thought it was because their local drug addict population was cutting their whatever they were injecting, was methamphetamines or heroin, with cefazolin. And they thought they literally got cefazolin powder and would put it in there, to use it to cut the drug, you know, and so that their customers didn't get sick when they injected themselves. And they really felt that way. And then, even though there wasn't a change in antibiotic prescription, there's no difference in antibiotic sensitivity. The USA 400 strain was first identified in the Detroit area. So it is kind of odd, and it's unexplained. But I'm not sure why they want to brag about it. It's sort of like bragging about being a Superfund site. Detroit has enough trouble getting everybody to stay with it. But anyway, that's an interesting thing, and that bug is the one that's the source of a lot of genetic investigation. And then group A strep and MSSA, necrotizing fasciitis are indistinguishable on clinical grounds when decisions on therapy must be made quickly. True, yeah. So we're forced to cover it. In the above situation, a cell wall active biotic or protein synthesis inhibitor are recommended. True, right? Why protein synthesis inhibitor? Do you remember? To block toxin production. Because toxins are often protein. Right? The third one's true. Yeah, we have to cover from MRSA now. We can't. And we'll do the UTI one next time.